So good afternoon, Chair and members of Council. Thank you for the opportunity to provide another public health update on COVID-19. So today I'll share an update on our local public health surveillance data, variants of concern, recent provincial announcements, and the status of the COVID-19 vaccine rollout in Halton. Next slide, please. So as of February 15th, Halton has seen over 9,000 cases of COVID-19. This includes 259 active cases and sadly 185 deaths. We've seen an overall decline in the 7-day average of new cases per day since it peaked on January the 6th at 114 cases. This decline likely reflects the success of lockdown measures implemented in late December. Currently, the 7-day average is sitting at 35 new cases per day, comparable to what was last seen in early November. While testing is more accessible now than it was during wave 1, we know that there are still many people not getting tested for various reasons. So we should always assume that our case count is an underestimate. Next slide, please. When looking at the same graph zoomed in to focus on the past 30 days, the recent decline in the 7-day rolling average is apparent, decreasing from 71 on January 16th to 35 on February the 15th. This means that the daily case counts are lower than what we were seeing a month ago, with some day-to-day fluctuation. This fluctuation can be driven by large outbreaks, including those at long-term care and retirement homes and correctional facilities. Next slide, please. Halton's weekly rate of COVID-19 peaked the week beginning January 3rd at 121.2 per 100,000. By the most recent week, beginning February the 7th, we were seeing a rate of 39.8 per 100,000. This means that for every 100,000 people living in Halton, about 40 of them were diagnosed with a new confirmed case of COVID-19 during that week alone. This doesn't include any cases from previous weeks, some of which remain active and in need of healthcare resources. Again, this rate is comparable to what we were seeing around late October of 2020. It does provide us with optimism that the rapid month-by-month increases we had previously been seeing until now in wave 2 have finally slowed, thanks to the recent stay-at-home order and enhanced measures that have been undertaken. An additional testament to the efficacy of public health restrictions such as physical distancing and reduced travel is the unprecedented low influenza activity in Halton and the rest of Canada this year. To date, we have seen only 3 confirmed flu cases in Halton for the 2020-2021 flu season. Next slide, please. So similar to what has been observed in neighboring health units, some groups in Halton are experiencing a higher percentage of COVID-19 cases than we might expect. Last summer, staff began collecting information about race, first language, income, and household size from residents with COVID-19. Collecting this information is not without its challenges. We are missing information for about 20% of our cases. Still, with the information we have, we know that 44% of non-institutional residents with COVID-19 in Halton did not have English or French as a first language, shown in dark green in the left-hand graph. This is much higher than the 2016 census data that shows only 25% of Halton's population does not have English or French as a first language, shown in light green. After English, the top 3 first languages provided by residents with COVID-19 are Arabic, Urdu, and Punjabi. Similarly, racialized groups accounted for 46% of people with COVID-19 in Halton. This is higher than the proportion of Halton's population who identify as belonging to a racialized group based on the 2016 census, which is 26%. When examining the ethno-racial identity of cases after white, the top 3 were South Asian, Southeast Asian, and Middle Eastern. While keeping in mind the limitations of missing data and that multiple cases in the same household can result in clustering of similar characteristics, we continue to explore reasons for these findings. They may relate to the interplay between factors such as gender, racialization, income, housing, and employment. For example, members of some racialized groups may be more likely to work in higher risk occupations or live in multi-generational housing. These findings will be important to keep in mind as we think about how best to reach all members of our community with vaccine messaging and offer vaccine clinics in locations that are accessible to as many people as possible. Next slide, please. The number of inpatients at Halton hospitals with confirmed COVID-19 has also followed a similar pattern to cases, but we know that the occupancy of hospital beds increases with a lag time of several weeks. This reflects the delay between the diagnosis of COVID-19 and the experience of severe effects that lead to hospitalization. This graph provides the breakdown by hospital with the 3 Halton healthcare sites in Oakville, Georgetown, and Milton, as well as Joseph Brant Hospital and the Joseph Brant Pandemic Response Unit in Burlington. Similar to the trends in cases and weekly rates, we have seen a decrease since the provincial stay-at-home order began in the number of beds occupied by confirmed COVID-19 cases. On the most recent day for which data are available, there were 31 inpatients in Halton hospitals with confirmed COVID-19. This represents a 44% decrease in the number of patients with COVID-19 in Halton hospitals over the last 30 days. Among the 31 cases currently in hospital, 13 or 42% are in the ICU. At the time a snapshot of inpatient demographic data was provided to us by our local hospitals, 73% were age 60 or older, with the remaining 27% between the ages of 20 and 59. Only 17% were known to reside in a long-term care home. This is important when remembering that while we are doing our best to immunize our long-term care home and retirement home residents who account for a large proportion of those who die from COVID-19, we must move on to immunizing other older adults in the community in order to reduce hospitalizations and relieve our healthcare system from the intense pressure it will face from the upcoming third wave. Next slide, please. Unfortunately, since the beginning of October, 116 new deaths among COVID-19 cases have occurred, raising the death toll in Halton to 185. Overall, the number of deaths has increased by 24% over the past 30 days. 142 of the 185 deaths have been among residents aged 80 plus, but the other 43 deaths occurred among residents aged 40 to 79. Next slide, please. This graph is taken from a recent scientific study in the UK, which assessed whether the higher risk of dying from COVID-19 among older adults can simply be explained by these individuals having more risk factors, such as obesity or high blood pressure. The study found that while these risk factors do play a role, adults age 75 and up remain at higher risk of mortality compared to adults under 65, even when those risk factors are taken into account. For example, looking at the graph on the slide, you can see that the most healthy adults aged 75 and up, shown in the red bar on the far left-hand side, still had a higher risk of mortality compared to the least healthy adults under the age of 65, shown in the green bar on the far right-hand side. This information and our own experience with deaths being concentrated among adults aged 80 and up in Halton, as shown on the previous slide, is helpful when we think about how to use factors such as age and chronic conditions to prioritize vaccine rollout in our community. Next slide, please. So while we have seen a decline in cases and hospitalizations recently, variants of concern pose a threat. Genetic variations of viruses, such as the one that causes COVID-19, are common. The term variant is used to describe situations when there have been several significant mutations to a virus. A variant becomes a concern when it affects disease spread, disease severity, tests used to detect the virus, or vaccines and treatments. We know that the variants of concern identified thus far are affecting disease spread. They are more infectious and more transmissible. Evidence is emerging every day about the severity and the effectiveness of vaccines for each variant of concern. We hope to have a better understanding about these other factors in the months to come. However, we are confident that the main way COVID-19 continues to be transmitted is through respiratory droplets, and this is true even for variants of COVID-19. This means that the public health measures we have in place to limit the spread are still effective, but it will take more intensive effort of these same public health practices to prevent transmitting variants of COVID-19. Letting our guards down even for a few moments is not an option. Next slide, please. The federal government is monitoring COVID-19 variants in Canada and around the world, including those initially identified in Brazil, South Africa, and the UK. As of February the 15th, 3 residents of Halton have been infected with a COVID variant of concern. As of February 15th, 319 residents of Ontario have been identified with a COVID-19 variant of concern, the majority of which were the UK variant. The proportion of COVID cases that are VOC positive are also increasing dramatically in Ontario. New data will be released at the end of the week provincially. Modeling has shown that doubling time for the variants of concern is in the order of 7 to 10 days, which is extremely troubling. These numbers tell us that variants of concern are here in Ontario, both from travel and community transmission. Urgent efforts are needed by all those involved in our collective public health response to slow their spread, protect our healthcare system resources, and protect our most vulnerable residents. Some efforts are already underway. At the federal level, we've seen more measures in place to discourage international travel and mitigate risks associated with returning travelers from outside of Canada. At the provincial level, the Ontario Lab Network is screening all positive COVID-19 cases for variants of concern. The province has also provided additional guidance for enhanced case and contact management for all confirmed and probable cases of COVID-19. And locally, we have enhanced our case and contact management, including lowering the threshold for classifying contacts as a high-risk exposure, prioritizing follow-up with cases that screen positive for variants of concern, and enhanced outbreak management for all high-priority settings. Information about variants of concern is available on halton.ca/COVID-19 and is being shared through our social media channels. I recently recorded a video about this topic, imploring the public to continue with following the practices that we had started last year, which include staying at home as much as possible and only going out for essential purposes, sticking with your own household and avoiding all indoor and outdoor gatherings with others, and taking symptoms seriously, even if they are mild. If you have any symptoms, self-isolate and get tested. Next slide, please. We received many questions about rapid antigen testing for COVID-19, so I would like to give you an update on rapid testing and how it's being used. Rapid antigen testing is a point-of-care COVID-19 test that yields results within 15 to 20 minutes, making it simpler and faster to identify potential COVID-19 positive cases. The test is mainly used to test asymptomatic individuals for screening purposes. A positive antigen result must be confirmed by a non-rapid PCR test, which is currently available at assessment centers. Currently, all rapid antigen screening is being conducted using the PanBio test. On January the 27th, the provincial government introduced a provincial antigen screening program to expand rapid testing in high priority settings, such as long-term care homes, retirement homes, essential workplaces, schools, and congregate living settings. This month, long-term care homes in Halton will begin using PanBio. COVID-19 rapid antigen tests to screen staff, students, and essential caregivers. The Ministry of Long-Term Care has set a deadline of March 15th for all long-term care homes to implement rapid antigen testing for essential caregivers. Once rapid antigen testing programs are fully operational in long-term care homes, PCR testing will only be used in instances where individuals are symptomatic or have a positive antigen test result, or individuals have been in contact with a confirmed COVID-19 case, or a home is in an outbreak, or otherwise directed by local public health. Next slide, please. So alcohol consumption may seem like an unusual topic to include in a COVID-19 update. In my presentation last November, I discussed the incidental impacts that the pandemic and public health measures have had on mental health and substance use. Today, I would like to highlight one incidental impact in particular, alcohol consumption. Prior to the pandemic, about half of adult residents in Halton consumed alcohol in a way that put them at risk for serious harm. Alcohol consumption is one of the few health indicators where Halton rates are less favorable than the provincial average. During the pandemic, research at the national level found that 14 to 25% of residents increased their consumption. And in another study, 26% reported that they had engaged in binge drinking in the past 7 days. Causes for increased consumption include having an irregular schedule, boredom, stress, and loneliness. Additional data are needed to assess the impacts of COVID-19 on the substance use behaviors of Halton residents. With research suggesting that Canadians have increased their substance use, it will be important to monitor local alcohol use. Staff are currently analyzing data from the rapid risk factor surveillance system that will give us an indication of whether alcohol use and the use of other substances has increased for Halton residents during the pandemic. I hope to bring this information to you soon. Next slide, please. As you're likely aware, yesterday, Halton returned to the control or red level of the revised COVID-19 provincial response framework. In the previous framework, there were no retail capacity limits for the control level. In the updated framework, grocery stores, convenience stores, and pharmacies are limited to 75% capacity. All other retail stores are limited to 50% capacity. These capacity limits must be posted along with signs asking patrons not to enter if they have COVID-19 symptoms. Many retailers in Halton have already posted signage outside their stores and are likely familiar with monitoring store capacity. Other requirements include screening patrons, recording contact information, and wearing a mask except when eating or being active in restaurants, bars, sport and recreation fitness facilities, and personal service settings. Restaurants and bars are limited to 10 people seated indoors per establishments, with no more than 4 individuals seated together. Team sports may train and practice, but no games or scrimmages are permitted. For community centers and multi-purpose facilities, the capacity limits set out above apply in respect of each room that is physically separated from other rooms in the facility. This was a confusing matter if you will recall last year. Personal care services that require removing a mask are not permitted at this time. Cinemas and performing arts facilities remain closed to the public. In addition to the province's requirements, I have issued updated instructions to shopping malls and retail stores to actively monitor compliance with capacity limits, ensure physical distancing, and the use of masks. These public health measures are intended to limit the spread of COVID-19 in Halton. Unfortunately, re-entering the provincial reopening plan is likely to lead into a third wave of COVID-19 based on the most recent modeling data from the province and the known community transmission of the variants of concern.